As per the ILAE, that is International League Against Epilepsy, epilepsy can be defined as a patient having 2 unprovoked seizures occurring more than 24 hours apart. So if the patient has 2 unprovoked seizures, not because of any substance abuse, not asymptomatic seizure, occurring more than 24 hours apart, then we call that patient is having epilepsy. Second, if the patient had a single unprovoked seizure, but the likelihood of this patient having subsequent seizure is more than 60% in next 10 years, then also we can call that patient as having epilepsy. Now the question is, how do we know if the patient will have a probability of 60% of having recurrent seizure? Should we wait for 10 years to make the diagnosis of epilepsy? The thing is, if the patient has specific EEG pattern or MRI brain pattern, then that patient is considered to be at higher risk of having a seizure and hence can be treated as epilepsy as per the diagnostic criteria. The third thing is, if the patient has an epilepsy syndrome. Epilepsy syndrome means specific EEG and MRI findings that are known to occur with those specific syndromes. If suppose patient has history of absence seizures and also has 3 Hz spike and wave discharges on EEG, then we will call that patient as having epilepsy syndrome, and that epilepsy syndrome is childhood absence epilepsy. So that means seizure is more like a sign and symptom, and epilepsy is a condition wherein the patient will have tendency for recurrence of seizures. And in such patients, it is imperative that we give anti-seizure medications for minimum of 2 to 3 years till the seizures are controlled. And depending on case-to-case basis, we decide to taper and stop the anti-seizure medications.